Hello everyone, good evening. Welcome to our webinar on current advances in breast cancer, organized by International Association of Oncology and Bioleagues worldwide, sponsored by CIPLA. We know breast cancer is the second most common cancer in women after skin cancer. And today we'll be discussing on the current advances in breast cancer with our experts who has joined us here today evening. Thank you, dignitaries who have joined us here. So firstly, I would like to welcome Dr. Ghanashyam Biswas, sir, who has joined us here. He's an eminent medical oncologist in the state of Orissa and prominent juror in the Cancer Society of the country. He is one of the leading medical oncologists of Eastern India, and he's a well-known name in the field of cancer treatment in Odisha and neighboring states. He is currently the consultant medical oncologist and senior executive director of Sparsh hospitals and critical care at Bhubaneswar. He is an expert with all procedures related to medical oncology, and he has a special interest in the areas of acute leukemia, lymphomas, and epithelial ovarian cancer. And today he'll be enlightening us on the human epidermal growth factor receptor MBC and HR positive. Thank you, sir, for joining us today. Welcome, sir.
Yeah, thank you, Jejila, and thank you, CIPLA and the Bioleagues for organizing today's event. So let us move to the first presentation. So you can present it, Jejila.
Yes, sir. I'll just introduce our other speakers who have joined us today here. And we'll also be accompanied by Dr. Chinmaya Kumar Pani in a short while, who is the top medical oncologist in Bhubaneswar at Apollo Hospitals, Bhubaneswar, with more than 14 years of experience. And his specializations are pediatric oncology and thoracic GI oncology, leukemia and lymphoma, urogen malignancy, and bone marrow transplant. And today he'll be discussing on the triple negative MBC. And we have been joined here by Dr. Chandrakanth MV. Welcome, sir, who is a renowned oncologist in Andul Road, Howrah. He has been practicing oncology for the last 16 years, and his specializations in the management of solid tumors like breast cancer, lung cancer, head and neck cancer, and so on. And in addition to it, he has also handled the management of GI, genitourinary and hematological malignancies like lymphoma, leukemia, and multiple myeloma. And he is currently working with Narayana Superspeciality Hospital in Kolkata. In addition to his vast array of experience, he has also done several publications to his credit in both national and international journals. And today he'll be talking to us on the de-escalation and escalation strategies in human epidermal growth factor receptor 2 MBC. Thank you, Dr. Chandrakanth, who has joined us here. So without any delay, we will move on to our talk, sir. And I hope all the participants are also eagerly waiting towards it.
So good evening all. I hope I'm audible and my slides are visible.
Yes, sir.
So I'll touch upon in next 20-25 minutes. I'll touch upon the landscape of HR positive, that is hormone receptor positive, ERPR positive, and HER2 negative metastatic breast cancers. So coming to the global scenario, so we talk about Globocan 2002. Sometime back we were discussing about 2018 data. So now sometime back we got 2020 data. So if you compare 2002 and 2020, so almost 2 decades. So in terms of total cancers, the prevalence have moved from 25 million to 50 plus, which is almost double. The incidence almost of 10 million to almost 20 million, and the death of 6.7 million touching up to 10 millions. On the left hand side, that is 2018 Globocan data, and on the right hand side we can see the Globocan 2020. So in each, on the left hand side, so you see the incidence in 2018. So lung was the commonest, followed by breast in terms of incidence. But if you see the 2020, it is breast cancers followed by lung cancer. In terms of mortality in 2018, so lung followed by colorectal, stomach, liver, and breast. So that almost remains same. So lung, in terms of mortality, is the highest, but breast cancer probably has taken upper hand in as compared to lung cancer. So now look at the MBC landscape. So almost 30%, that is 1/3 of women who have already early disease, will develop a metastatic disease in the natural history, so as they are going to live long. And 10% of all women with breast cancers will present with a metastatic disease at the initial diagnosis, maybe a bit more if we talk about our country. So now how to segregate that? Because now we will have 3 speakers. So I'll talk upon the most common presentation, that is hormone receptor positive, and Chandrakanth will speak on the HER2 positive amplified disease, and Dr. Chinmaya Pani will talk about the triple negative. So if we talk about HR positive, so almost 60% will be HR positive, HER2 negative, and 15% will be a triple positive. And there will be 10% who will be HR negative, that is ERPR negative, HER2 positive, and triple negative constitutes almost 15%. So endocrine therapy is the oldest targeted therapy in breast cancers. So you can see the estrogen receptor, the estrogen, and the target tissues are breast tissue, peripheral tissue, and the tumor tissue. So what this estrogen and the estrogen receptor does is actually causes proliferation and angiogenesis, which is a hallmark for any cancer. So this slide shows how things have advanced in terms of hormonal manipulation in breast cancers. So if you go back to the historical, so it was all in surgery and radiations, and later on we moved into the medical treatment for hormonal aspect of breast cancer. So early 1900s, so oophorectomy, and then so it was by George Bateson that we understood that so these breast cancers are hormone sensitives. In 1950, estrogen derives breast cancers. 1977, so estrogen receptor identified and tamoxifen got the approved, that is the ACRMs. And in 1990s, so the IC developed for an ERPR analysis, and today we know that ERPR, HER2/neu, and to some extent Ki67. So that is the basic immunohistochemistry required for treating a breast cancer. So whether it is a metastatic or for an adjuvant or a neoadjuvant. So 1999, so first selective aromatase inhibitors approved for ABC, and today we know that so aromatase inhibitors holds the forte for breast cancer in regards to hormonal therapy. So in early 2000s, we found out so there is something called ER down regulators that got approved, and subsequently AI, that is aromatase inhibitors, also got approved in the adjuvant therapy of a breast cancers. 2010, so anti-HER2 plus the aromatase inhibitors approved for triple positive advanced breast cancers. 2012, the Bolero-2 for patients who have progressed on hormonal therapy. So mTOR inhibitors like everolimus got approved with exemestane, that is steroidal hormonal agents of aromatase inhibitors. And so last 6 years have been an era of CDK4/6 with combinations of either aromatase inhibitors or with the ER down regulator, that is fulvestrant. So continuing with that, so tamoxifen is a selective estrogen receptor modulators, and as I talked about aromatase inhibitors, so anastrozole and letrozole are non-steroidal whereas exemestane is a steroidal. Fulvestrant, selective ER degraders. We know that initial days when you started treatment with fulvestrant, it was a lower dose of 250 milligram, and we now know that. So we are used to the 500 milligram, the higher dose of fulvestrant actually, and that came into approval in 2010. So we have used quite some time with everolimus and exemestane, and we know the toxicities of this Bolero trials without no much of PFS benefit, but at times it comes handy. So this was there prior to the CDK4/6 inhibitors. So once we have entered into the CDK4 era, so probably this combination is almost going out of place. And so 2015 post, so we had the first approval for palbociclib. Then that was from the Pfizer, subsequently ribociclib from the Novartis, and so this year, in fact, we got the other drug, that is abemaciclib, third in the row of CDK4/6 inhibitors from the Eli Lilly. So we'll have another group of patients, so where there will be a PIK3 mutated. We see that almost 35 to 40% of HR positive, HER2 negative breast cancer patients will be actually having a mutation in the PI3K alpha inhibitors, and that's how. So we got another drug in combination with fulvestrant, that is alpelisib. So in HR positive, HER2 negative MBC, the impact of treatment decreases after the first line. So on the left hand side, so if you can see the yellow is the first line therapy and the light greenish is the second line therapy. So if you are at all you are advocating endocrine monotherapy, so you can see almost 16 months of PFS. So whereas these patients one progressed on the second line, so it is less than 5 months. So we are almost coming out of chemotherapy unless and until the patients of hormone positive are in visceral crisis. So you can see if you have used as a first line chemotherapy in less than almost 9 months of PFS, so you can see, so in the second line, so once this progress, so it is less than 5 months. And now with last 6 years with a CDK4/6 combination, you can see that all these three drugs have shown more than 2 years of PFS. And once this patient progresses, once they are offered, if they are PIK3 mutated, you can see they are candidates for a PIK3 inhibitors, and you can see still expect a PFS of 10 months. The importance here is that the best chance for optimal response is always in the first line. So how do you select your treatment in HR positive advanced breast cancer? So the multiple things are important here. So a site and extent of disease, the organ function, the prior systemic therapy the patient received for early breast cancer, length of disease-free survival, rate of disease progression, and today we talk about so much of genetics. So definitely BRCA1, BRCA2 mutations, comorbidities, quality of life. So everything need to come into place. And if at all we define as a visceral crisis, probably this cohort of patients will receive chemotherapy as of now. But again, there's emerging data of using a CDK4/6 combination with aromatase inhibitors, even in these subsets of patients. So if you look at the TMH data published some time back, so the amount of ER/PR positive we see from the TMH data is almost like 50%. Whereas in the West, you can see it is much more, that is almost 75 to 80%. So probably we see a lesser amount of, we see younger patients, and we see more triple negative as compared to the West. Similar has been seen from one of these AIMS data from AIMS Delhi. You can see, so ER/PR positive HER2 negative is almost 43%, and ER/PR HER2 new triple positive is 16%. So something like 55%. So this is again some AIMS data. So what was the endocrine therapy that was offered prior to CDK4/6? So after 234 patients who was supposed to receive endocrine therapy, so almost 82% patients received some or the other form of endocrine therapy, and tamoxifen in almost 38%, aromatase inhibitors either of from anastrozole, letrozole, or exemestane in 42%, and others, that is 1.7%, is usually a fulvestrant. So the role of CDK4/6 in breast cancers, the growth of HR positive MBC is dependent on cyclin D1, a direct transcription of a target of ER. Cyclin D1 activates CDK4/6, resulting in the G1S phase transition and cell cycle entry. Some cell line models of endocrine resistance show dependence on cyclin D1 and CDK4/6. So cyclin D1 and CDK4/6 drive cellular proliferation downstream of signaling pathways. So coming to CDK4/6 inhibitors in postmenopausal and premenopausal women with HR positive, HER2 negative MBC. So in the first line setting, we can see these are all phase 3 studies. So the first in the row is a Paloma 2 from the Pfizer, Mona Lisa 2 from the Novartis, and Monarch 3 is from the Eli Lilly group. So these are all first line. The Mona Lisa 3 had a combination of first line and second line, and the Mona Lisa 7 had a premenopausal group, which was probably looking at a premenopausal, particularly premenopausal group. So, so all these have the aromatase inhibitors, letrozole. In the Monarch 3, the choice was either letrozole or anastrozole. So you can see there was a good number of patients, around 600 plus patients in Paloma and Mona Lisa, around 500 patients in the Monarch 3. And so in the premenopausal group, there is Mona Lisa 7, again around 670 patients. So the striking thing here, in all the first line setting of MBC, HR positive, HER2 new, you can see a beautiful hazard ratio of 0.5 across all the trials and across all the class molecules of CDK4/6. Coming to PFS, so as compared to hormonal agents, endocrine therapy versus endocrine therapy plus CDK4/6, you can see almost all the drugs have more than 25 months of PFS. Coming to ORR, you can see that there was also a significant response rate as compared to a single that is placebo plus aromatase inhibitors. So this is across all the trials and with all the drugs. So Mona Lisa 2, if you look at the efficacy by the biomarker analysis, so ribociclib treatment benefit was maintained irrespective of baseline protein levels of RB, Ki67 and P16, and gene expressions levels of CDKN2A, CCND1 and ESR1. PIK3CA alterations detected in the cytoplasmic DNA of almost 34% of evaluable patients. The most important, the ribociclib treatment benefits similar for the PIK3CA wild type versus the mutated group. So this class of drugs, CDK4/6, is also active in the premenopausal patients regardless of the endocrine therapy partner. So Mona Lisa 7 was predominantly, so it was only for a premenopausals, so where tamoxifen was also used, and if you are using an aromatase inhibitors, then you need to use the GnRH analogs. The only problem is that, so we know that Mona Lisa 7 used ribociclib. So ribociclib can cause a QTC prolongation, and this tamoxifen can also cause a QTC prolongation. So probably tamoxifen and the ribociclib may not be a good combinations looking at the cardiotoxicity. In the Paloma 3 from the Pfizer, again you can see 100 plus patients of premenopausal. Monarch 2, so which is supposed to be in the trial, so where probably primary resistance and quite a good amount of patients in the premenopausal groups were also taken. And we can see from all these graphs, so the median PFS was significantly improved in all these trials in the premenopausal women, showing that this drug is not only active in the menopausal setting but also in the premenopausal setting. So there is another trial of Parsifal. So whether to use a CDK4/6 with fulvestrant or aromatase inhibitors in the endocrine sensitive in the first line. So whether to use both oral or one oral plus injectable. So the palbo plus fulvestrant versus palbo plus letrozole. So this was just to look at the non-inferiority, and the end result was that so the outcome is almost the same. So you are using palbo with fulvestrant or palbo with letrozole. So definitely somebody who is not keen for injection, so definitely the palbo plus letrozole stands to the new standard. And we can see, so neither is superior in terms of responses or in terms of an overall survival. So now coming to the second line setting, and the second line phase 3s are, so the Paloma 3, Mona Lisa 3, and the Monarch 2. So these are previously treated patients, and here because most of these patients have been used aromatase inhibitors. So here the partner with the CDK4/6 drug is a fulvestrant, and this fulvestrant dose is a high dose. You can see here again, so 500 odd patients in the Paloma, 700, almost 700 patients in the Monarch 2, around 346 patients in the Mona Lisa. Again, such a beautiful hazard ratio of 0.5 across all trials. PFS almost doubling in all the three trials, and again a significant overall response rate. But in the Monarch 2, probably we'll see more of difficult to treat patients like PR negative. So we have many primary resistance, endocrine resistance patients. So this is how probably in time to come you want to segregate all these three drugs, that they are, though they are of the same class, so maybe action wise different. So relatively high overall response rate. So many of us think that so probably chemotherapy gives a response rate, but again, so if you are talking about a luminal A type of disease, so even with a hormonal treatment or hormonal treatment with CDK4/6, so we can get a beautiful response rate as compared to chemotherapy. So you can see in the first line setting and the second line setting, so you can see, so almost there is a significant improvement in the overall response rate as compared to the only hormonal agent on the endocrine therapy alone. So there's a Monarch 1 also. So this is probably this is different from the other palbo and ribociclib in terms that, so you can use these drugs also as a single agent, but in a combination we use as a 150 milligram BD continuous dosing. But in this Monarch 1, that is heavily pretreated patients where a 200 milligram dose was given. So probably if you are given a situation so where the patient is multiply treated and you want to use a single agent, so at this moment the approval is only for abemaciclib. So we can see there will be patients of HR positive who will also present with the brain metastasis. So this is the only drug though that is a subset analysis, and it has been seen in the phase 2 that abemaciclib, that CDK4/6 also has an activity in the brain. So do all these CDK4/6 inhibitor result in an improvement in the OS? So you can see from the Mona Lisa 3, so there is an absolute overall survival benefit. So there is a reduction in relative risk of death with ribociclib, 28%. So if you compare ribo plus fulvestrant, so the median overall CS is not reached, whereas in the standard arm it was 40 months. Since Mona Lisa 3 had a first line and a second line, so if you see on the left hand side first line, again you can see there was a survival benefit in terms of OS, and on the right hand side early relapse plus second line, again you can see so there is a numerical OS benefit also. So Mona Lisa 7 OS benefit in the premenopausal group, so 29% relative reduction in the risk of death. So you can see in terms of 36 months, 71 versus 64, in 42 months, 70 versus 46. So Monarch 2, you can see the overall survival. So in the combinations of abemaciclib, fulvestrant, 47 months versus 37 months in the standard arm. So Paloma 3, also there is a non-significant trend towards improvement OS with the fulvestrant and palbociclib. So that shows that, so all the three drugs, so not only overall response rate, DFS, but also showing a OS benefit. So how do you compare? So CDK4/6 inhibitors versus chemotherapy. So there is a young Pearl trial. So where palbo, exemestane, and leuprolide, because these were premenopausal ladies, versus capecitabine was compared. The primary endpoint was PFS, and you can see, so the PFS benefit was again for HR positive, HER2 negative in the premenopausal group, so that favored the CDK4/6 combination with endocrine therapy versus the capecitabine. So toxicity management and monitoring. So this is a summary slide of toxicity of all the CDK4/6. So this group of drugs has a class side effects, and so probably you will see some of the other toxicities, so that are common with particular drug, and looking at the patient's comorbidities and clinical parameters, so probably you will choose one of these drugs. So abemaciclib probably is notorious in diarrhea, but as of now I have used in few patients. So as of now diarrhea is not a problem with our patient population. Hepatotoxicity is a problem with ribociclib. QTC prolongation are already an established cardiac comorbidities, so ribociclib is not the choice. So neutropenia is common with palbo and ribociclib, initial 2 to 3 months, and then the patient settles down. So abemaciclib, neutropenia is not a major problem. And with all these drugs, so these are all of, there is a function or cyclical neutropenia. These are not like the chemotherapy-induced neutropenic, so they don't land up in neutropenic fever. So venous thromboembolism, abemaciclib, and all these three drugs can cause even 1 to almost 3% of patients, they can cause ILD or pneumonitis. So Paloma 3 effect on PFS of dose reductions, because so once you reduce the dose, suppose so this is like the Paloma 3. So the standard dose of palbociclib is 125. The first reduction is 100, then 75. So this graph shows that if you are reducing the dose, so the survival is not compromised. So dose modifications. So out of these three drugs, abemaciclib is the only CDK4/6 which is given as a continuous dosing, whereas the abemaciclib and the palbo and ribociclib are given in a 3 weeks on and 1 week off fashion. So in abema, so if you want to have a dose reduction, so you move from 150 BD to 100 BD, and the second dose reduction is 50 BD. Whereas in palbo, 125 followed by 100, then 75. And the ribociclib is easy because from 3 capsules of 200, you can move down to 2 or 1. Looking at the ABC of 5, so endocrine-based therapy is the preferred option for hormone receptor positive disease, even in the presence of visceral disease, unless and until so your definition for this patient is not a visceral crisis. So this was a practical consensus from many of our colleagues in the country, got published in one of our Indian journals. So what is your preferred treatment for patients hormone positive? So we are slowly moving away from chemotherapy to either endocrine therapy or endocrine plus CDK4/6 inhibitors. So this is a real world treatment of CDK4/6. So 2015, so when just CDK4/6 a group of drugs was available, and today 2018 and 2021, we can see slowly the chemotherapy bar and the single agent endocrine therapy is coming down, and the combination is taking an upper hand. So we cannot forget the Bolero 2. So this is one of those published from Tata. So still there are patients who can be offered everolimus, though many patients doesn't tolerate. So you can move down from 10 to 5 with the combinations of an exemestane. So this can work for a few patients who are not a candidate for a CDK4/6 or who cannot afford for a CDK4/6 inhibitors. So this is a SOLAR-1 trial. This is a phase 3. So these are all these patients who have progressed on a CDK4/6 combinations with aromatase inhibitors. You can do a PIK3 mutations on the previous block or a fresh biopsy block, or you can do on a circulating DNA. So if you pick up PIK3 mutated patients, and so these patients can be offered alpelisib with fulvestrant, and this is shown. So this group of drug has a peculiar toxicity, and we know that India is a hub of diabetics. So many patients can land up with uncontrolled diabetes. So you need to select up these patients. So especially, so once you are considering alpelisib for the treatment, so the patient should not have type 1 diabetes or uncontrolled type 2 diabetes. In the SOLAR-1 trial also, there are 56% of the patients who were borderline diabetes or a pre-diabetes, and only 4% of them were diabetes. This may not be true in the situation in our country, because we have more diabetics than the rest of the world. So 2020 virtual ESMO. So the overall survival of SOLAR-1 was published, which is a phase 3 alpelisib plus fulvestrant, and we can see, so this drug had a PFS benefit of 11 versus 5.7, but they did not translate into a OS benefit. But if you compare a subset of patients who had a lung or a liver metastasis as compared to a bone-only metastasis, so probably there was some advantage, though numerical, statistically not significant. So OS in the PIK3 mutated cohort was a secondary endpoint, because the primary endpoint was PFS. So though a 7.9 numerical increase in median OS was observed with this combination of PIK3 plus fulvestrant. So the approach to therapy for HR positive HER2 MBC, so we moved to personalization. So we didn't have much options, and today we are talking of first line, second line, and third line and beyond. So this is how. So once you pick up HR positive HER2 negative breast cancer, metastatic breast cancer, then probably you need to have, is it a high endocrine sensitive disease, or a moderate endocrine sensitive disease, or a poor endocrine sensitive disease, and then you choose your therapy. So to conclude, increasing use of CDK4/6 inhibitors in India, and many of our colleagues we have been hearing in different webinars. So my other two speakers have also a rich experience of these drugs. Outcome fairly comparable with the Western data that shows that in the real world setting also, this combination is doing wonders. So definitely for a country like us and many other developing countries, so cost remains an important issue, though there are so much of support program associated with this company. So cancer incidence continue to rise. The global, you can see. So we cannot say that we are drifting away from this. So we can see the 2020 again is showing that there is a significant rise in cancer in the world. So at the end, cancer, it's personal. The right patient, the right treatment can offer and can improve a survival. Thank you so much.
Thank you so much, sir, for that amazing presentation. And with this, we will move on to our next doctor who has joined us here, Dr. Chinmaya Pani. Hello, sir.
Hello, am I audible?
Yes, sir. How are you doing?
Yes, I'm good. All well.
Yes, sir. We'll begin in a while.
Yeah. Can you show my presentation?
Yeah, sure.
Yeah.
Just a moment, sir, because of the network issue. It's just taking a few minutes to
Yeah,
upload.
yeah, yeah. Okay, not an issue, not an issue.
Yes, you may begin, sir.
Yeah, is the okay? Screen position is fine.
Yes, sir.
Should I speak? Yeah. So, good evening to you all. So, thank you, our program director, Dr. Ghanashyam Biswas, for giving me the opportunity to speak about the triple negative breast cancer. This is one of the very aggressive subset of the breast cancer. Don't behave in a good way. Okay, let us proceed to my presentation. So recently, the Globocan 2020, the data what they show that the breast cancer outnumbers the lung cancer, and the incidences of the new cases of the breast cancer is quite high, and it is almost on the top. And the number of deaths due to the breast cancer is almost in the range of 6.9%, though the globally the number has been reduced, but this is not that reflect in India. In India, the incidences is in the range of 13.5%, and which surpass also the lip and oral cavity and the cervical cancer in India, and so also the death is also very high, that is 26.3%. So, if you see the receptor status and correlating with what is the percentage of the ER and PR positive, that the hormonal positive, which is almost in the range of globally 65 to 70%, but in India it is 55 to 60%. The HER2 positive in the range of 15 to 20% in India, and in globally, but in India it is around 20 to 25%. And if you see globally the aggressive biology, that's the triple negative breast cancer, our number is quite high than that of the globally, so in the range of 20 to 25%. So, how can the TNBC could be stratified? There are so many ways we can stratify TNBC. In 2016, one of the very seminal paper presented, and they classified TNBC into basically 6 to 7 subgroups. But if we classify it generally, and the TNBC and basically basal by the Claudian law and the basal diet, from low to high immunogenicity and low proliferation index to the high proliferation index, and the and so also the hypertrophy index, and so also the high chemosensitivity. And this is another way, because it is one of the targetable way, I can say, in a druggable way, I can say, for seeing the overview of the TNBC. That is one of the things, is that in the germline BRCA and BRCA2. So defective DNA repair, and where the platinum and the PARP inhibitors mostly active. And another one is the histologic examinations for the tumor infiltrating lymphocyte, and this is the immunosignature for the DNA expression microarray, and where the immunotherapy plays a very, very important role. The other one is the where the androgen receptors are positive, and the androgen receptor pathway androgen blockade may have a prominent upcoming role. The other one is the sequencing for PIK3CA AKT pathway and the PTEN alterations is seen, where the AKT inhibitor could be a potential target for therapy, and the IC for the targetable for the epithelial antigens, where the unique antigen expression and maybe the antibody drug conjugate, which is also coming under the way, that is very valuable. And other one is the unclassified TNBC, where the chemotherapy still plays the only viable options. And to support the evidences of the immunotherapy and other things, there are various number of the trials going on to see or to formulate the impact of different kind of therapy. Sorry, yeah. So if we see what are the options we have for the metastatic TNBC in the line of the chemotherapy. So we had taxanes, paclitaxel, nab-paclitaxel dosing. We have anthracycline, the doxorubicin, pegylated doxorubicin, and epirubicin. We have antimetabolite, the JM and capecitabine, microtubules inhibitor like the vinorelbine, eribulin, and exabepilon, and the platinum. The first question is that whether the doublet should be given or the single agent chemotherapy. The sequential single agent chemotherapy is the preferred approach for most patients with metastatic TNBC, but in the patient where the visceral crisis is there, where the doublet plays an important role, though it does not improve the overall survival. So patients should generally remain on a regimen until the best response or disease progression or the significant toxicity. So point number one, these are the choice, and how to use this choice one by one. So that is the question. For selections of the chemotherapy agent, so we have to decide what is the durations of relapse from the adjuvant therapy, what is the site of relapse, whether it is CNS or non-CNS, or how much the visceral, how much the volume of the disease, whether it is a visceral crisis or not in a visceral crisis, and what is the choice of regimen that you have, whether it is in lipodox or in the taxanes, the nab-paclitaxel, dosi, and conventional paclitaxel, or eribulin, capecitabine, or the platinum. So this is one of the landmark study because we tend to use paclitaxel in the both in BRCA1 positive and the BRCA1 negative, the triple negative. So to know the impact of the therapy, there is a trial called the TNT trial, where the carboplatin, there's a head-to-head comparison between the carboplatin and the docetaxels in the triple negative breast cancer, and the subgroup analysis done on the BRCA1 and 2 basal-like and the HRT biomarkers. So if you see in the response, the statistically significant response seen in the BRCA and BRCA2 with all patients or intent to treat populations, it is 31 versus 35. In the no BRCA and BRCA2, it is 28 versus 36. And in the crossover means carboplatin to dosi or dosi to carboplatin, it is 22 versus 25 with significant, not significant. So this so in the response when it is considered, definitely in the BRCA and BRCA2, we have advantage of carboplatin in comparison to dosing. In other cases, we don't have substantial data of one over the other. And so also the median progression survival is carboplatin is 3.1 month versus the docetaxel is 4.5 months. So the overall survival is similar, but when you analyze the PFS by the BRCA and BRCA2, obviously the carboplatin outperform in the BRCA and BRCA2, that is 6.8 versus the non-mutated one, the 3.1, or in the docetaxel 6.8 versus 4.8 in the BRCA and BRCA2, the carbo versus dosi. So coming to the other trials of the EMBRACE trial of eribulin versus the physician choice at the time of the therapy. So they have used very capecitabine, vinorelbine, and other thing. So one group is the eribulin versus the treatment of the physician choice. And the 2 to 5 prior chemotherapy and anthracycline, and this is post-anthracycline, post-taxane, and the patient populations are that. So when they analyze the progressive survival, it is not significant, but when they analyze the overall survival, the eribulin is 13.1 versus the 10.6, which is statistically significant with a p-value of 0.04. And when they analyze the hormonal negative and triple negative patients, which is almost in the range of 20%, and thus they saw that definitely the ER negative, PR negative, and HER2 negative subgroup, definitely the advantage of overall survival is there and retained in the eribulin subgroup of patients than that of the the standard of care. Sorry. So this was the another paper which is in the metastatic breast cancer after anthracycline and taxane, the in comparison to eribulin versus the capecitabine, and this is the overall survival, and which is not significant. So whether to give eribulin and to give capecitabine, the final done meta-analysis of this 301 and the embrace trial, who is they could not found much significant benefit of the eribulin, but still as the phase 3 trial of the embrace definitely an advantage of the eribulin is significantly same. So, and the two things what I left is the combination therapy. What should be the combination therapy? Usually, we tend to give the combination therapy with gemcitabine along with the cisplatin or the carboplatin as per the renal dysfunction is considered in the duplet regimen. And so also there is a considerable amount of evidences to give anthracycline recharge in the form of lipodox, and if the favorable safety profile and cardiac status is fine. So then come to the next topic of the impact of the path inhibitor in a selected patient with the TNBC with BRCA and BRCA2 mutations. The first thing is that when to treat the BRCA and BRCA2 mutation in MBC as per the current data. So the patient factor is less than 50 years of age diagnosis, less than 60-year diagnosis with the TNBC, diagnosis of bilateral breast cancer, and history of ovarian cancer at any age or in the first and second degree relative. And when the family history, the first degree relative diagnosed with breast cancer is less than 50, more than 2 first and second relative diagnosed with breast cancer at any age, male breast cancer, and grandparents with a Jewish ancestor. So that could be the reason of doing the BRCA and BRCA2 testing, when to test and how to test. Supporting that evidences, we have a trial of the Olympiad trial. Olympiad is olaparib versus the standard of care in the germline BRCA and BRCA2 mutations in triple negative breast cancer. So the TNBC less than 2 prior line of chemotherapy, and olaparib versus the standard of care. In the standard of care, they have used eribulin, capecitabine, and vinorelbine. And this is the progression-free survival. That is in olaparib, the PFS is 7 versus the 4.2, which is statistically significant with the p-value of 0.001. And the overall survival also 19.3 and 19.6, which is not significant. So definitely there is a PFS benefit seen in the olaparib group. And when they analyze the adverse event, definitely the nausea, the gastrointestinal complication, and so also the anemia particularly is high anemia, and a little bit of gastrointestinal complications like that of vomiting and fatigue. Irrespective of that, except this, the other part is quite okay and reasonable to manage the adverse effect of this. Then then there are other 2 trials. One is the data of the tolazoparib and tolazoparib 1 milligram, which is also coming in a good way. Another one is the iniparib in combination with gemcitabine and cisplatin. I'm not going to that detail, but that also in the phase 2 variant, the iniparib also saw a significant advantage, and so also the tolazoparib. But tolazoparib, because of the toxicity specifically, it is not given much data input into the system. So another thing is that so there are various data now coming up with the immunocheckpoint inhibitor with metastatic TNBC. My first question is, where is the concept of the using immunotherapy in the TNBC? Because TNBC has a highest tumor mutation burden amongst all breast cancer subtypes. More mutations lead to the more neoantigens to be recognized by the antigen-specific cells that can ultimately start an anti-tumor immunoresponse. So supporting this hypothesis, the TIL, tumor-infiltrated lymphocytes, are frequently present in the TNBC samples, and increased level of the TNBC associated with a good prognosis. And particularly the TNBC subset is considered as an interesting subset for the development of the immunotherapy. This is one of the classic trial, though that has not been given the substantial benefit, is a phase 2 study of the pembrolizumab in patient with the TNBC with more than one systemic therapy, the the biomarker-driven approach for the immunotherapy, PD-L1 may not be an adequate or maybe an robust biomarker, so that you can say, but this trial does not show any much substantial the benefit of the pembrolizumab in the subset of the patients of TNBC with more than one systemic therapy. So this pembrolizumab with the PD-L1 is the cohort 1, the pre-treated, and the cohort B, the previously untreated patients. And you see the untreated patient, the overall response is 23%, wherein the PD-L1 positive pre-treated patients, the overall response rate is of 9.5 and the DCR is 9.5. In the in the pre-treated patients is 9.5, in the untreated patients are also in the range of 23. And this does not give much benefit when you see the overall survival and the progressive survival. No such benefit and seen, and the survival also not that great to the PFS of the 2.1 month. But it gives us an good insight to see that how can we find it out. So later on, came the data of phase 1b trial of the atezolizumab along with the nab-paclitaxel metastatic TNBC. So this is less than 2 previous line of systemic chemotherapy. They have given atezolizumab along with the nab-paclitaxel day 1, day 8, day 15, and every 2 weekly the atezolizumab they have been given of 800 milligram. And then after day 15 there's a 14 days gap, and the cycles go on, and the quite substantial the median duration of exposure. The median safety follow-up was 6.1 month and median duration of exposure 5.4 for atezolizumab and 4.2 for the nab-paclitaxel. No death reported. So basically, it is safe. And simultaneously, they analyze the outcome, and they saw the first line data is quite substantial, but not in the second and third line. The CR rate in the first line data was almost number 8, so which is actually good. So that gives us an impetus to go for the phase 3 data, and here comes the impact of the IMPASSION 130 background. So in the metastatic TNBC, the poor prognosis compared that to the other breast cancer subtype. The IMPASSION 20 is a global randomized phase 3 double-blind trial of atezolizumab along with nab-paclitaxel with placebo plus nab-paclitaxel. Co-primary endpoint was progression survival and overall survival in the intent to treat populations along with the PD-L1 positive patients, which is more than 1%. And the PFS analysis demonstrated significant survival benefit in the atezolizumab plus nab-paclitaxel versus the placebo, specifically in the PD-L1 positive subset of patients, those who are more than 1 plus. And this is the overall survival in the PD-L1 positive populations, and the number of deaths significantly really less, which is almost in the range of 65 versus the 75 in the in the placebo group in the PD-L1 positive cases. But when they analyze the overall survival in the clinical subgroup analysis in the PD-L1 populations, and they saw one thing that even in the liver metastasis, extensive liver metastasis is good, but prior taxane exposure has if it is prior taxane, the response is not good. But before if no prior taxane exposure, definitely the effect is much better than anything. And so also the white Asian populations, the number is less and probably doesn't show the much benefit in the group of the people. And so to clarify to summarize the IMPASSION 130 data, so here we report the mature OS data In the pre-specified final overall survival analysis, the OS boundary for the stat-pad sequence was not crossed in the intent to treat populations, precluding the formal testing, but clinical meaningful OS is observed in the PD-L1 positive populations. And the overall survival is 0.67 and point over and 7.5 month overall survival improvement is seen, and the OS result is also the PD-L1 positive population consistent in the first and second interim analysis of a overall survival of 0.62 in the first interim analysis and 0.71 in the second interim analysis. And important is, as the phase 2 trial said, it is safe, remains safe and tolerable. So on the basis of this, this is approved as a first-line therapy in the PD-L1 positive metastatic TNBC cases. So this is another one of the study recently published in 2020 ESMO Virtual Congress, is the randomized phase 3 study of the sacituzumab govitecan versus the treatment of physical choice in patients with previously treated metastatic triple-negative breast cancer. This is basically a antibody drug conjugate, a topo-2 inhibitor along with the topoisomerase inhibitor, antibody drug conjugate. And so here the subgroup of, and this is the trial recently published, that the treatment of physician choice and versus the sacituzumab, and you see the patient population. Then we analyze, it is well balanced study, but they have previous taxane exposure, anthracycline exposure, multi-chemotherapy agent exposure, previous PARP exposure, and previous also the immunotherapy exposure is also there, and both BRCA1 and BRCA2 positive patients are also there, and they are a heavily treated patient. So when they analyze the progression-free survival in the group, and surprisingly, irrespective of the age group and race, except the Asian populations and the previous therapy, two-line therapy, three-line therapy, different kind of regimen they give, in spite of irrespective of the PD-L1 status, irrespective of the extent of disease and initial diagnosis. So irrespective of all things, it gives a statistically significant analysis across the all group. And when they analyze the tolerability and the toxicity profile, and it is, I can say, it is a well-managed toxicity profile, though the number of the neutropenia are in the 51 versus 33. The diarrhea number is more, 10 versus 1. And leukopenia is 10 versus 5%, anemia is 8 versus 5%, and febrile neutropenia is 6 versus 2%. There are more GCSF used in the sacituzumab arm, and the dose reduction and was similar in the both groups. So I can say these are all the manageable toxicity, and it can be the survival the adverse but can be surmounted by giving the GCSF, prophylactic GCSF, and in the planned approach, and this could be a reasonable good way to manage the thing. So it is after a long time you get an antibody drug conjugate for the triple-negative breast cancer, and which is evidence in that trial. This is the first phase 3 study with the topo-2 directed ADC, the sacituzumab govitecan, in the pre-treated, multiple treated metastatic TNBC to demonstrate significant improvement over the standard single agent chemotherapy, with the median progression PFS is 5.6 versus 1.7, statistical significant, and overall survival 12.1 versus 6.7, and the response is in 35%. And so both across the subgroup, overall response, PFS and OS benefiting across all subgroup, and it is well tolerated with a manageable toxicity. And I can say the toxicity can be surmounted by giving the supportive care in terms of the GCSF, though it should be considered in the standard of care in the pre-treated metastatic TNBC. So I hope the drug will come to the market soon for the clinical use. So, so to conclude, in the setting of the metastatic breast cancer, TNBC is relatively higher, accounting a larger number of breast cancer deaths due to its highly aggressive biology. And for those patients presenting with metastatic disease, The anthracycline-based chemotherapy with or without a taxane would be an appropriate first-line approach. There is no protocol for the first-line metastatic treatment in previously treated TNBC patients who are subsequently presented with metastatic disease, and sequential monotherapy where there is no visceral crisis is appropriate. Combination therapy in visceral crisis is strongly recommended. Platinum-based therapy in TNBC with or without BRCA mutations is useful, but not yet the standard of care. PARP inhibitors offers a novel mechanism action in BRCA mutated patients, and we should explore this possibility very often by doing the rampant testing of the BRCA1 testing, and so also the immunotherapy is an option of the TNBC with a PD-L1 expression of more than 1%. The data of the VEGF and anti-VEGF and anti-VEGF therapy is not a standard of care of what we see, what we were using of late in I think the 2012 to 2013 addition survivalismab along with the gemcitabine and cisplatin, and which is phase 2 shows a greater benefit in the response, which is not reflected later in the phase 3 trial or in the overall survival. So that is not a standard of care as of now. So I think I'm done with this. So thank you very much for your patience hearing. It is I can say the science is evolving. There are a lot of things that are coming in a good way, and we just need to take the benefit of the advancement of science. Thank you very much.
Thank you so much, sir, for the amazing presentation that you have given to us. And attendees who are live in the room, as well as those who are watching us live on YouTube, you may write to us your queries in the chat box as well as in the comment box. And with this, we'll be continuing our session with Dr. Chandrakanth, sir. So can we move on to your presentation, sir? Is it visible to you, sir? Sir, your mic is off. Can you please enable it? No, sir, I cannot hear you. Sir, you can enable your mic right on top. You will have option to turn audio on. Hello, sir.
Yeah, am I audible now?
Yes, sir. You're audible now.
Yeah. Okay.
Thank you, sir.
So, well, thank you and apologies for the delay. And I would thank Cipla Oncology for providing me this opportunity. I think after two wonderful talks by Dr. Ghanashyam and by Dr. Chinmaya, I will be the last to speak. So let me keep it short and sweet. So we have spoken about hormone receptor positive breast cancer, then about triple negative breast cancer, and now third is the HER2 positive breast cancer. So the topic is mainly on the adjuvant therapy, escalation and de-escalation. What is there in the future? So there have been a lot of options for a HER2 positive breast cancer. There have been attempts to reduce it, and there have been attempts to increase the number of agents. So we will look into both the uh, strategies which have been used with good evidences. So we all know that early breast cancer outcomes have substantially improved over the last 20 years, even though in the Indian setting, because we don't have routine mammographs being done as a part of screening, we pick a little bit of less early breast cancers. We pick up more of locally advanced breast cancers where we see a nodal disease. However, a significant proportion do present in a non-metastatic fashion, and that's the reason why we are able to cure majority of non-metastatic breast cancers. So if you look into adjuvant therapy of a HER2 positive breast cancer, so we attempt on one end to give more stronger agents, more potential agents, longer duration of therapy. We want to use combination of anti-HER2 agents on one end, whereas on the other end, we will try to give lesser duration of therapy, lesser agents, and even spare some patients from chemotherapy. So this is the de-escalation approach. So the ultimate aim is to make the patient free of cancer with the least possible side effect I can give to the patient. So for the adjuvant chemotherapy part, we are having anthracycline, cyclophosphamide, and paclitaxel or taxane, being these three drugs being the backbone of any breast cancer chemotherapy, and we have anti-HER2 agents being present in combination with this for the HER2 positive breast cancer. So HER2, so we spoke of ER positive, we spoke of triple negative, and now this is HER2 positive. So among the three, ER positive is the best because they are hormone positive, they are low grade tumors. You can see the luminal A and luminal B. So basically they are sort of ER positive tumors. They do better than the basal. The basal is the yellow one, which is very bad because we don't have a proper target in it. So the way oncology is growing is we are trying to find out targets in any cancer. You take lung, you take breast, you take kidney, everywhere we are looking into targets, the mutations which are there, the driver mutations which are there in each cancer, and target that particular mutation. And this is helping us to improve outcomes in cancer patients. So luminal A, luminal B are sort of hormone receptor positive. We are able to target these with anti-hormonal therapy. Therefore, we are able to improve outcomes. Whereas if you come to HER2 positive breast cancer, HER2 positive breast cancer also has a target, and if you can target that, its outcomes are also in par with the hormone receptor breast cancer. But if you do not target, in itself HER2 is a poor prognostic variant. So HER2 positive is as bad as triple negative breast cancer if I don't give a drug that targets this particular mutation. But if I can target it, the outcomes are in comparison to that of the luminal A and the B types. So HER2 positivity, yes, is a poor prognostic marker. But if I can target this with effective anti-HER2 agents, their outcomes are incomparable to hormone receptor positive breast cancer. So it all comes about finding out the target and giving the most potent drug to this particular target. So this is so in oncology we have so many targeting molecules. We heard of molecules like sacituzumab govitecan. We heard of pembrolizumab. We heard of atezolizumab. In oncology, there are very few molecules that has revolutionized cancer care. Among that, I think trastuzumab tops the list, where it has changed overall survival. It has added life to the patient. So there are majority of oncological drugs improve quality of life. They cause some responses. They give some progression-free interval. But we have very handful of drugs that actually change the natural history of disease. Among them, trastuzumab tops the list. So you can see all the three classical trials. I think any oncologist, when he goes through the medical school, these are the start trials that we go through: the HERAD trial, the NCCTG, the BCIRT6. So you can see that all the three trials, if I can add this drug trastuzumab, that is anti-HER2 antibody, how beautifully it adds life to the patient. You can see the hazard ratios being consistently good in all the three trials. So we have this particular molecule that has actually revolutionized breast cancer management. It is because of this particular drug we are speaking so much on escalation and de-escalation strategies. So then again, to look into which subgroup benefits the best in a HER2 positive breast cancer, age doesn't matter, whether younger or older, whether the primary tumor is bigger or doesn't matter. So all the subgroups benefit. However, an advanced stage and a hormone receptor positivity are sort of prognostic markers among the HER2 population. So if you look into a breast cancer, we always speak that yes, breast cancer is a localized disease. I operate it and I'm done with it. Why do I need adjuvant chemotherapy? Why do I need to give chemotherapy? So it is said that once the size of the breast tumor is more than 0.5 centimeters, it becomes a systemic disease. We will be able to detect cancer cells in the blood. Therefore, any tumor more than 0.5 centimeters becomes a systemic disease, and these patients need systemic therapy. So if you look into a very small tumor, T1A or T1B tumor, that is less than 2 centimeters or so, if you look into the risk, so HER2 positivity in itself is prognostic. So if the patient has HER2 positive and you have not given anti-HER2 therapy, their outcomes are inferior to that which are HER2 negative. So HER2 in itself has a negative prognostic influence. This is the trial. So as I was saying you, active chemotherapy drugs for a breast cancer is anthracycline, cyclophosphamide, and taxane. Among these, we are always concerned of anthracycline. The reason is cardiotoxicity. So anthracyclines are more toxic when compared to the taxane combination. So our entire effort is to eliminate taxane in this HER2 positive subgroup, eliminate anthracycline. So the reason why we want to eliminate anthracycline is trastuzumab and anthracycline share a similar toxicity profile, that is cardiotoxicity. So there has always been an attempt to eliminate this anthracycline from majority of breast cancer treatment trials because of the shared toxicity profile. We also call anthracycline as a poor man's trastuzumab when trastuzumab was expensive. However, in the era where trastuzumab is affordable by majority of patients, there has been always an attempt to eliminate anthracycline, which is cardiotoxic, from the breast cancer management. So in this select subgroup, what we call as the Tolani trial or the APT trial, where this was a phase 2 trial, this was not a randomized trial. They included breast tumors that had less than 3 centimeters and node negative disease, a very early tumor, which we come across during practice. In these trials, what he did was he eliminated anthracycline completely. So he gave 12 cycles of trastuzumab plus paclitaxel, followed by trastuzumab for 1 year, what is known as an anthracycline-free regimen. So this was practice changing in that he showed an excellent disease-free survival, 3-year DFS 98%, and whether it is HR positive or HR negative, there is a little bit of difference, but you can see the intent to treat population DF is 98% at 3 years and 93% at 7 years. So what I can say is you cannot improvise beyond this. 98% DFS is too much. So if I add an anthracycline, I won't be able to improvise beyond this. So therefore, above all, the guidelines have more or less accepted that anthracycline can be safely eliminated from the breast cancer adjuvant regimen if the tumor size is less than or equal to 3 centimeters, less than 3 centimeters. So if we have a 3 centimeter or less than 3 centimeter breast tumor, anthracycline free regimen using paclitaxel plus trastuzumab for 12 weeks followed by trastuzumab for 1 year, the standard of care, because of this excellent 3-year disease-free survival. Then going on, well, if I give targeted therapy, the cells become resistant to it by various mechanisms. By reducing the expression of these receptors, we do see in around 10 to 15% patients, as the tumor progresses, a HER2 positive disease may become a HER2 negative disease. So in these resistant, trastuzumab resistant population, we have what is known as edotrastuzumab, or what we call as the TDM1. So this is basically an antibody drug conjugate. So we want to we use antibody, that is trastuzumab, that goes and attaches to the HER2 receptor, and there is a thioether link, and there is a chemotherapy moiety which we call as M-tansin being attached to it. And this M-tansin is lethal to the tubules in the cells. So I am using trastuzumab not just to kill the cell by targeting the HER2 receptor. I am also using this so that I attach an active chemotherapy drug to its tail by a linker, what we call as a payload, and then I will make these payloads or these chemotherapy drugs reach the target. And once trastuzumab attaches to the HER2 receptor on the surface, these active chemotherapy drugs get inside the cell and they kill the target cells. So it is a double purpose. Trastuzumab in itself reduces HER2 signaling, and secondly, this chemotherapy moiety gets inside the cell and eliminates the target cell. So this is what we call as an antibody drug conjugate. So this is a phase 2 attempt trial where they found this TDM1 to be quite effective in the trastuzumab resistant population. So they wanted to eliminate chemotherapy also from the adjuvant chemotherapy backbone. However, this trial was a negative trial in that, so the baseline characteristics were well matched, but you can see here that the disease-free survival was almost similar between the two arms. The antibody drug conjugate did not prove superior to the paclitaxel plus trastuzumab regimen. However, the toxicities were also not that better in the TDM1 arm compared to the paclitaxel trastuzumab arm. Therefore, this is not practice changing because it was not better in its efficacy, nor it was better in its toxicity profile. Therefore, adjuvant trastuzumab in an early breast cancer, adjuvant TDM1 in an early breast cancer is not the standard of care. Even today, the Tolani et al., that is paclitaxel trastuzumab followed by trastuzumab maintenance, is still the standard of care in the adjuvant treatment of breast cancer that are less than 3 centimeters. So now that we have understood how to treat a smaller breast tumor in a node negative disease where we can use an anthracycline-free regimen. Now we will look into what are the neoadjuvant therapy options in a HER2-positive breast cancer. So why use neoadjuvant therapy? So there were all well accepted reasons which we all read in our undergraduate schools. If I give neoadjuvant chemotherapy, I will shrink the tumor. I can have a higher breast sparing or breast conservation surgery. I will be able to handle the micrometastasis, and I can have some biological selection which subgroup is progressing or not. So very importantly, after the Catherine data, before the Catherine data, neoadjuvant chemotherapy did not add to survival. That is, giving chemotherapy before surgery did not add life to the patient. It only shrink the tumor. It only changed a modified radical mastectomy to a breast conservation surgery. So this is what it did. Or if the surgery dates were delayed, I could use this in the meantime just as a window so that the disease does not progress. But after the Catherine data, what neoadjuvant chemotherapy, neoadjuvant therapy in breast cancer has become a little revolutionary. So I give a trastuzumab-based neoadjuvant anti-HER2 therapy. After that, operate the breast and see what is the amount of efficacy of this drug by looking into what is known as pathological complete response. If the neoadjuvant chemotherapy has eliminated all the cancer cells in the operated tissue, what we call as pathological complete response, I would continue with trastuzumab maintenance alone. If the cells have not died, there are viable cells. If I have not attained a pathological complete response, I will escalate my treatment with a better drug, that is TDM1, which I just discussed before, and this has added life to the patient. So with this strategy, I will be able to select out those patients in whom giving trastuzumab alone will not be sufficient. I can add life to the patient if I can give a more potential drug in those subgroup where there is no pathological complete response. In other ways, I will be able to improve life of a patient if I can give neoadjuvant chemotherapy than giving adjuvant chemotherapy. Therefore, if I have a tumor more than 3 centimeters, as a rule, we must offer neoadjuvant systemic therapy, trastuzumab-based neoadjuvant systemic therapy in all patients. Not that neoadjuvant anti-HER2 therapy adds life directly, it indirectly helps in selecting patients who are not going to do well. It selects patients who do not attain a complete pathological response, and in these subgroup patients, I will be able to augment my adjuvant therapy by giving TDM1. So therefore, neoadjuvant anti-HER2 therapy has become very popular and has almost been accepted as standard of care in locally advanced breast cancer or a breast cancer that is more than 3 centimeters. I will look into the trial. I will explain you the trial and after a few slides. So, well, this is what I said was pathological complete response. There has always been a debate. Should my endpoint be pathological complete response? Endpoint should be overall survival. So why is a pathological complete response a surrogate marker? See, these adjuvant trials are where the patients are not going to die soon. They're going to live, they're going to have their normal lives. So keeping overall survival as an endpoint needs a longer follow-up. So when I have an active drug and I want a longer follow-up, for example, 5 years, 7 years, I will not be able to give this active drug for the coming 5 to 7 years. So having these surrogate endpoints like pathological complete response, you can see in this particular, there has been a good correlation between a pathological complete response and event-free survival. You can see the red and the green curves. If I have a good PCR, the event-free survival is far better than not having a pathological complete response. You can see these barred charts, the blue, purple, yellow, and green. So if I add trastuzumab in a hormone receptor positive versus hormone receptor negative, so the highest pathological complete response is in the yellow. That is, I have given trastuzumab to the patient who is HR negative, HER2 positive, which is the highest, followed by next higher pathological response in those patients who received trastuzumab in HER2 positive, HR positive patients. So to simply to say that if I add trastuzumab, we are increasing pathological complete response rates, and this pathological complete response correlates with event-free survival. So who should be considered for preoperative systemic therapy for HER2 positive early breast cancer? Any tumor more than 2 centimeter, more than or equal to 2 centimeter is what the guideline says. So however, Tolani did mention that up to 3 centimeter I can do. But if you look into the inclusion criteria of the Catherine trial, even they have included tumor size more than 2 centimeters. So in the present era, if you're coming across early breast cancer, T size more than 2 centimeters, HER2 positive, we must offer neoadjuvant therapy because I can add life to these patients. So these are the neoadjuvant trials we have. This is an attempt to add pertuzumab. So pertuzumab plus trastuzumab is what is a dual HER2 blockade. So if I add more HER2 blockade, dual HER2 blockade, do I add life to the patient? This is what we have. If I am adding dual HER2 blockade, trastuzumab plus pertuzumab, so these two act at two different receptor levels. Pertuzumab prevents heterodimerization of HER2 receptors. If I am adding a dual HER2 blocker, that is pertuzumab plus trastuzumab, I will be able to increase the pathological complete response rates, which is a surrogate for event-free survival. Therefore, there is a role for dual HER2 blockade in the neoadjuvant systemic therapy of HER2 positive breast cancer. So this is another data from the Trifina study, again, where dual HER2 blockade using trastuzumab, pertuzumab, along with chemotherapy, improves pathological complete response rates. Remember, pathological complete response rates are highest in a hormone receptor negative population when compared to HR positive population. Then coming on to the adjuvant therapy part. So we spoke of adjuvant therapy. First part we spoke of adjuvant therapy in a low risk disease. Second part we spoke of neoadjuvant therapy in a locally advanced disease. And we said that neoadjuvant therapy should be given in patients who have a breast tumor size more than 2 centimeters. And now we will see what is the adjuvant therapy in high risk HER2 positive early breast cancer. So this is what we have. We have a tyrosine kinase inhibitor coming over here, neratinib. Then we have pertuzumab plus trastuzumab, the famous and now a little bit infamous affinity trial. And then we have the TDM1, which is the Catherine trial, which is change practice. So let us go to the clinical evidence with each of these drugs. So this is the affinity trial where, so we looked into the neoadjuvant, the Trifema study, where if I could add dual HER2 blockade in the neoadjuvant setting, I could improve pathological complete response rates, which is a surrogate for event-free survival. Here they have used dual HER2 blockade in the adjuvant setting. So adding dual HER2 blockade, yes, has a bit of benefit, but not that great. I have a hazard ratio of 0.76. So in the node positive cohort, little bit more benefit, whereas in node negative cohort, there is not much benefit. Therefore, combining trastuzumab plus pertuzumab, dual HER2 blockade is beneficial, especially in a node positive subgroup and not in the node negative subgroup. So the invasive disease-free survival by HR status in the intent to treat population, we can see in the HR positive subgroup, hormone receptor positive, the hazard ratio is 0.73 and HR negative it is 0.83. So little bit of counter evidence is that the long-term follow-up of the affinity data, the overall survival benefit is not there. So dual HER2 blockade in the adjuvant setting because of lack of OS benefit has sort of become obsolete right now because of lack of long-term OS benefit, and that's the reason why we can give an accelerated approval. There is no problem, but we have to have a long-term data where it has not reflected for overall survival, probably because the magnitude of benefit we had was very small, and this hazard ratio of 0.8 is not that great to offer an overall survival benefit. So, however, it is not compulsory to have trastuzumab plus pertuzumab combination in patients of high risk. If I am giving it, I will be giving it in a node positive patient and not in a node negative patient. So safety is reasonably fine with pertuzumab. It doesn't add too much cardiotoxicity. Then coming on to neratinib, which is a HER2 TKI. So neratinib is a pan-HER TKI. It just doesn't inhibit the HER2 receptor from outside. It's an irreversible pan-HER TKI. It has a mechanism of action different from pertuzumab and trastuzumab. So neratinib was given post completion of 1 year of trastuzumab in node positive and also node negative disease. You can see that early breast cancer stage 1 to stage 3 were included in this, and the primary endpoint was invasive disease-free survival. And the dose was 240 milligram once a day for 1 year. And you can see the 5-year invasive disease-free survival has a hazard ratio of 0.73 and significant p-value 90 versus 87% at 5-year invasive disease-free survival. In the HR positive subgroup, the hazard ratio is 0.6. In the HR negative subgroup, the hazard ratio is 0.95. So HR positive subgroup shows a better hazard ratio. Neratinib, when added post completion of 1 year of trastuzumab, improves invasive disease-free survival. Therefore, adding neratinib is sort of an augmentation. It adds extra life to the patient after completing 1 year of trastuzumab. So you can see the benefit without PCR, the delta becomes 7.4%. Then this is the Catherine trial, which is the practice-changing trial right now. We have, so let us go into the details of the study. So this particular trial was an international randomized open label phase 3 trial. It included HER2 positive breast cancer. You can look into the inclusion criteria. It had T1 to T4 and N0 tumors, and who had residual disease in breast or axillary nodes after neoadjuvant HER2 directed therapy. The randomization was TDM1, standard dose for 14 cycles versus trastuzumab for 14 cycles. The primary endpoint was invasive disease-free survival. Secondary endpoint was distant disease-free survival and overall survival and safety. So if you look into the type of cancers they had, you can see that 75% had operable disease. So if a HER2 positive patient comes to you, operable, still you can offer neoadjuvant therapy based on the inclusion criteria of this particular trial. You can see in nearly 80% there was trastuzumab alone, and in rest 20% there was dual HER2 blockade used. So even if you give pertuzumab plus trastuzumab in the neoadjuvant setting, this particular trial included 20% of those patients, and you can see an excellent invasive disease-free survival difference with a hazard ratio of 0.5, which we hardly see in oncology. So TDM1 given what we call as augmentation of adjuvant HER2 therapy based on pathological complete response rates. In those patients where there was no pathological complete response, if I can augment the adjuvant therapy with TDM1 than continuing trastuzumab alone, we have a 3-year invasive disease-free survival, which is statistically different, and the hazard ratio is 0.5. Then you can look at all the subgroups, HR positive, HR negative, whether I have used pertuzumab, trastuzumab, or trastuzumab alone, node positive, node negative, all the subgroups have benefited, and the hazard ratios are more impressive. And you can see in the node negative subgroup, the hazard ratios are much more impressive than the node positive subgroup. And remember, 75% of patients were operable breast cancer as per the inclusion criteria of this trial. So these are the secondary endpoints: distant recurrence and overall survival. Of course, overall survival are quite immature. We need to have a long-term follow-up, but distant recurrence is again statistically significant. And hazard ratio for OS is also 0.7. So these are the class side effects of TDM1: transaminitis, fatigue, low platelet count, and discontinuation was required in 18% patients. So then quickly going through further, so eliminating chemotherapy completely using TDM1 plus pertuzumab in the adjuvant setting did not show great benefit. So this says that I cannot eliminate taxane trastuzumab chemotherapy. I have to use, even if I use the most expensive drugs like pertuzumab plus TDM1, that is not the way to go. I need to use trastuzumab plus taxane in the adjuvant setting. So this is the patient-reported outcomes we have, and this is the Christian trial. This is again the similar thing. I cannot omit taxane trastuzumab, even though I have TDM1 and pertuzumab in my hand. That is what the trial is saying. So this is another excellent study. So we saw anthracycline-free regimen in early breast cancer of T size less than 3 centimeters. Here we have anthracycline-free new adjuvant chemotherapy regimen where they have used double HER2 blockade with pertuzumab, trastuzumab, and they have used paclitaxel plus carboplatin in the new adjuvant setting. And this trial has clearly showed that we may get away without anthracycline if I am using a double HER2 blockade in combination with paclitaxel and carboplatin. So TRAIN 2 is another practice-changing trial. I can eliminate anthracycline not only in early breast cancer, I can eliminate anthracycline even in a locally advanced breast cancer if I can use dual HER2 blockade with pertuzumab plus trastuzumab, and I use paclitaxel plus carboplatin in the new adjuvant regimen, because the pathological complete response rates were comparable. So that is about eliminating anthracyclines. Quickly going through the slides. These are the new trials. So what we can do right now, these are the proposed management. So if I have a T1A-B tumor size less than 3 centimeter, I'm okay using an anthracycline-free regimen, paclitaxel plus trastuzumab for 12 cycles weekly, followed by trastuzumab for 1 year. So if I have a locally advanced tumor, if the tumor size is more than 2 centimeter or more than 3 centimeter, more than 2 centimeter as per Catherine, we must give, if possible, the black box inside is not visible. So what is written is dual HER2 blockade should be included if feasible as a new adjuvant regimen, because we could see the trifema data where if I can use pertuzumab plus trastuzumab plus chemotherapy in the new adjuvant, I can improve pathological response rate. If there is complete pathological response, continue the same anti-HER2 regimen which I use in new adjuvant setting, and I can add neratinib for 1 year after completing the standard anti-HER2 therapy. So neratinib 1 year 240 milligram OD has improved invasive disease-free survival. If there is residual disease, we have to augment the HER2-directed therapy by adding TDM1, because we have data on based on Catherine data with a hazard ratio of 0.5. So that is about augmentation and elimination trials which we spoke of, and this is the ongoing trials which we have, and this is summary. So the similar thing: less than 3 centimeter, anthracycline free; more than 3 centimeter, give neoadjuvant therapy. If I want to eliminate anthracycline, give dual HER2 blockade. So moving a little bit away from HER2 positive, we had CREATEX study where adjuvant CAPE who did not have PCR did benefit. So this is a metronomic dose of capecitabine where they have used irrespective of PCR, and even this has shown some benefit. And these are the differences between Createx and this metronomic capecitabine trial. However, so what I can get from this particular trial is giving a lower dose continuous capecitabine is also feasible because it is less toxic. So the whole purpose of treating early breast cancer is to have the best anti-cancer, our best cancer survival and best cancer outcomes with least possible toxicity which we can have. So these are some MIND-ACT trials that we have. This was basically the MammaPrint data where they have further analyzed. So MammaPrint data did meet its primary endpoint of predicting being prognostic of which subgroup chemotherapy can be avoided. This is something like Oncotype DX. They used distance metastasis-free survival as an endpoint. So yes, it is prognostic. MIND-ACT is prognostic, but its predictive value is not that great to that of Oncotype DX. So this is another alternative trial where they used neoadjuvant hormonal therapy in ER-positive patient, and they tried to look into reduction in Ki-67. However, this was not a positive trial, still not practice changing. So with this, I will come to the conclusion of the trial with few take-home messages. So what are my take-home points today? So HER2-positive disease has a poor prognostic influence, definitely. But if I can give good HER2-directed therapy for an optimal duration, I can definitely improve outcomes in HER2-positive patients. Secondly, if I have a T size more than 0.5 centimeter, this is no longer a localized disease, this is a systemic disease, and I must give systemic therapy. If the T size is less than 2 centimeters, I'm comfortable eliminating anthracycline completely, and I can give a taxane and trastuzumab-based regimen alone. If the T size is more than 2 centimeters, even if the breast is operable, I should not be operating the breast. I should be giving neoadjuvant HER2-directed therapy. If possible, a dual HER2-directed therapy in the neoadjuvant setting. If there is a complete pathological response, I can continue trastuzumab maintenance for 1 year, followed by neratinib for 1 more year. It has shown benefit. If there is no complete pathological response, we must be using TDM1 in the adjuvant setting for 1 year because of improvement in invasive disease-free survival. And then in the neoadjuvant setting, I can omit anthracycline if I can use a dual HER2 blockade plus paclitaxel plus carboplatin as per the TRAIN2 study. So with this, there has been a lot of options in HER2-positive breast cancer. So with this, I would come to the conclusion, and I would thank everyone for their patient listening. Back to you. Ghanashyam sir, you can take up.
Yeah, thank you, Chandrakanth, and thank you, Chinmay. I don't know. So if there are no questions, so we can call it a day. So it is all 9:20 now. Jijina has joined. Thank you, and thanks the Bioleague team.
Thank you, Dr. Chandrakanth. Sorry about the technical glitches that we are facing due to the network issue. And thank you to Dr. Ghanashyam sir, and thank you to Dr. Chinmaya sir, who had joined us today for this session. Irrespective of your busy schedule, you have shared your valuable time with us in imparting knowledge on breast cancer and spreading awareness. And special thanks to CIPLA, who has brought about this kind of awareness program. And thank you to IAO and Bioleagues Worldwide for bringing about more of these kind of webinars and conferences frequently on cancer and other oncology topics. So before we wind up, I would like to take a few questions from our YouTube subscribers who have been watching us throughout. So if you don't mind, can we take up some questions, sir?
Yeah, please.
We have a question from Dr. Kamal Krishna, where he has been asking, is vitamin E significant for FBD?
I don't know. Sir. Just check out the relevant question to breast cancer, no?
Sure, sir.
Just check out if there are any relevant questions to.
So we have been receiving the common question frequently on how they can prevent breast cancer. So can you just give us some quick tips to the normal participants or the patients who can get into it very quickly? Just few tips.
So there are certain things which are reversible and there are certain things which cannot be changed, like the age, the sex, the menopause, the menstrual status. And so there are certain things that can be changed, like the weight. So really regular exercise, the control of diabetes, so avoiding or control of the hypercholesterolemia. If there is a positive family history, so definitely a screening methods can be taken out. So we can see probably there is a rise of breast cancers. We have seen the global data. So most of urban population, so today females are getting into a service mode, and that's why so the pregnancy is getting delayed, and after the childbirth, so the breastfeeding is not optimum. So I think so that these are certain reasons that probably there's a rise of breast cancer today.
Thank you, sir. So with this, we come to the end of our webinar. And once again, thank you to Dr. Ghanashyam Biswas, Dr. Chinmaya Kumar Pani, and Dr. M.V. Chandrakanth, who has joined us today. And thank you to CIPLA once again for organizing this webinar. And thank you to all the attendees who have joined us live in the room, as well as those who have been watching us live on YouTube. So if you have any questions, you can write to us at webinar@indooncologysummit.com. And to follow us more on our events, do follow us on our Facebook, LinkedIn, and Twitter and Instagram pages. So thank you once again to all, and have a nice day. Thank you, sir.
Yeah, good night.
Good night.
Good night.